Welcome to our lesson on Introduction to the 12 lead ECG. This is going to cover chapter 9 in your book, so just make sure if you haven't already that you read through that chapter as well to help supplement this lesson. So the first thing I want to do is give you a little introduction into the ECG. So a standard 12 lead ECG is going to provide us with views of the heart in both the frontal and the horizontal planes and views of the surfaces of the left ventricle from 12 different angles. So these multiple views of the heart can provide a lot of useful information, like things like identifying the ST segment and T wave changes that we see that are associated with things like an MI, injury, and even infarction. It can also help us with identifying the ECG changes that we see or that may be associated with medications or even electrolyte imbalances. And it can also help us recognize bundle branch blocks as well. So there may be several different indications or reasons why someone may need to be hooked up to a 12 lead ECG for us to monitor them and see what's going on. On this slide, we'll see a list of the many of the things, but it's just not limited to this slide. There may be other reasons as well, but these are some of the more common reasons. Things like abdominal or epigastric pain, assisting in any type of dysrhythmia interpretation. They're having chest pain or any discomfort. If they're in DKA or what we call diabetic ketoacidosis, they're complaining of dizziness, they have dyspnea, any electrical type of injuries, a lot of times that can affect the heart. So if they're electrocuted, if they have any known or we have any type of suspected electrolyte imbalances, same thing, any known or suspected medication overdoses, if they have right or left ventricular failure, if we need to know what their status is before or after electrical therapy, just to check the status of the heart before they go into electrical therapy, and then again after, if they've had a stroke, any syncope or near syncope, and any unstable patient that we don't know or they have an unknown etiology, and we don't know what's going on. These are all reasons why we may hook somebody up to that 12 lead ECG. So now we're going to get into the layout of a 12 lead ECG. So most 12 lead monitors, are going to record all 12 leads simultaneously, but they're going to display them in a conventional 3-row by 4-column format. So the standard limb leads are going to be recorded in the first column. The augmented limb leads are going to be in the second column, and the chest leads are going to be in the third and the fourth column. So you can sort of see here in this little chart that you see on the slide, on this PowerPoint slide, you see your standard leads in column 1, your augmented leads in column 2. We also see in our third and our fourth column, we see our chest leads. So V1 through V3 and V4 through V6. So what you see here, as far as this picture is concerned on the slide, is this is going to be an example of a 12 lead electrocardiogram or ECG. And what you'll see is that 4-column format used on the majority of the page. So what we're seeing is a continuous recording of lead V1 is going to be shown at the bottom of the page. Now the 12 lead ECG provides about a 2.5 second view of each lead, but basically that's done because it is assumed that 2.5 seconds is long enough to capture at least one representative complex. So although we'll see with most 12 lead ECG machines that will obtain the signals for all leads at the same time, other machines obtain the signals sequentially. So, for example, all limb leads, then the augmented limb leads, followed by leads V1 through V3, and then finally leads V4 through V6. So now we're going to get into vectors. So first I want you to know that leads have a negative and a positive electrode pole that senses the magnitude and direction of that electrical force caused by the spread of waves of depolarization as well as repolarization throughout the myocardium. So a vector is also known as an arrow, and basically what it is it is a symbol that is representing this force that I just explained. So a vector is going to point in the direction of depolarization. Leads that face the tip or point of a vector are going to record a positive deflection on ECG paper. A mean vector is going to identify the average of depolarization waves in one portion of the heart. The mean P vector is going to represent the average magnitude and direction of both the right and left atrial depolarization. Whereas when we see a mean QRS vector, what this is going to represent is the average magnitude and direction of both right and left ventricular depolarization. Now we're going to touch base on what an axis is. So the average direction of a mean vector is called the mean axis and is only going to be identified in the frontal plane. So an imaginary line joining the positive and negative electrodes of a lead is called the axis of the lead. So once again, an imaginary line that's joining the positive and negative electrodes of a lead is going to be called the axis of the lead. Now, electrical axis is going to refer to the net direction or angle in degrees in which the main vector of depolarization is pointed. So when axis is used by itself, it's going to refer to the QRS axis. So what you see here on this slide is Einthoven's equilateral triangle formed by leads 1, 2, and 3. So the axes of leads 1, 2, and 3 form an equilateral triangle with the heart at the center, which is also known as Einthoven's triangle. So Einthoven's law states that the sum of the electrical currents recorded in leads 1 and 3 equals the sum of the electrical current recorded in lead 2. So this can be expressed as lead 1 plus lead 3 equals lead 2. Now what you see in this picture is the augmented leads that are added to the equilateral triangle. So if the augmented limb leads are added to the equilateral triangle and the axis of the 6 leads moved in a way in which they bisect each other, the result is the hexaxial reference system, which is what you're seeing right here. So what we're looking at here is the hexaxial reference system, which is derived from B. So the hexaxial reference system is going to represent all of the frontal plane, which is our limb leads, with the heart in the center, and is the means used to express the location of the frontal plane axis. So what this system is going to form is a 360-degree circle surrounding the heart. So the positive end of lead 1 is designated at 0 degrees, which you can see on the right over here. The 6 frontal plane leads are going to divide the circle into segments. Each is going to represent 30 degrees. So all degrees in the upper hemisphere are labeled as negative degrees, and all degrees in the lower hemisphere are labeled as positive degrees. So when we look at these two figures on the screen, we have A and we have B. So A is going to be to the left, B is the one to the right. So what we're going to be looking at is the axis of electrical activation. So our figure A, the one on the left here, is what we're going to see here are vectors for the limb leads in the frontal plane. In figure B, the picture to the right there, a hexaxial reference for determining the frontal plane axis is what we're looking at. So what I would like you to look at is that the vectors for leads 1, 2, and 3 are in the same direction as in figure A, but now, similar to the augmented limb leads, these standard limb lead vectors have been moved so that they emanate from the center of the figure. So in the hexaxial reference system, the axis of some leads are perpendicular to each other. So lead 1 is perpendicular to lead AVF, lead 2 is perpendicular to AVL, and lead 3 is perpendicular to lead AVR. So if the electrical force moves toward a positive electrode, what we're going to see is a positive or upright deflection on our ECG strip. If the electrical force moves away from a positive electrode, a negative or downward deflection will be recorded on that strip. If the electrical force is parallel to a given lead, the largest deflection in that lead is what will be recorded. Now, if the electrical force is perpendicular to a lead axis, the resulting ECG complex will be isoelectric or equiphasic or both in that lead. What I want you to also notice is that leads 3 and AVL are positioned on opposite or reciprocal sides of the hexaxial reference system. So what we're going to be looking at doing here is really sort of the determination of the QRS axis quadrant by noting the predominant QRS polarity in leads 1 and AVF. So the normal axis is going to be seen if the QRS is primarily positive in both lead 1 and AVF. The axis falls within the normal quadrant from 0 to 90 degrees. If we have right axis deviation, what's going to occur is the QRS complex is primarily negative in 1 and positive in AVF. Right axis deviation is going to be present if that exists. Now, when we get into left axis deviation, the QRS complex is predominantly positive in lead 1 and negative in AVF. In an indeterminate axis, the QRS is primarily negative in both 1 and AVF, and we have a markedly abnormal, indeterminate, or northwest accent that is present. Lead 1 and AVF divide the heart into 4 quadrants. So these two leads can be used to quickly estimate electrical access. In leads 1 and AVF, the QRS complex is normally going to be positive. If that QRS complex in either or both of these leads is negative, axis deviation is present. So to determine electrical access, what we want to look at is a 12-lead ECG, like what we have here on this slide. Because the hexaxial reference system is derived from the limb leads, we will mainly be focusing on the leads shown in the 2 columns on the left side of the figure. So what we're going to be looking at here are leads 1, 2, 3, AVR, AVL, and AVF. What we're looking for is the most equiphasic or isoelectric QRS complexes in these leads. Lead AVL shows QRS complexes that most closely reflect our criteria. So once again, that's going to be lead AVL is what's showing us those QRS complexes that reflect the criteria we're looking for. So the patient's QRS axis is perpendicular to positive electrode in lead AVL. So at the top of this picture here of the ECG strip, what you're going to see is the computer's calculation of the patient's PQRS T axis. So the computer calculated the patient's QRS axis at a plus 56 degrees. So our estimate of 60 degrees was very close on our previous slide. Acute coronary syndromes, or what we call ACSs, are conditions that are caused by an abrupt reduction in coronary artery blood flow. So partial or intermittent blockage of a coronary artery may result in no clinical signs and symptoms, and that would be an example of silent ischemia. We could also see things like unstable angina, what we also call UA, a non-ST elevation MI, which is an NST EMI, or possibly even sudden death. So complete blockage of a coronary artery may result in ST elevation MI, once again, STEMI, or sudden death. UA and NSTEMI are often grouped together as non-ST elevation acute coronary syndromes, which is played out as NSTE-ACS. And that's because ECG changes associated with these conditions usually include ST segment depression as well as T wave inversion in the leads that face the affected area. The diagnosis of an ACS is made on the basis of the patient's presentation, their history, ECG findings, as well as cardiac biomarker results. If ST segments are elevated in two contiguous leads and elevated cardiac biomarkers are also present, the diagnosis is the STEMI. Now, if the ST segment elevation, STE, is not present, but biomarker levels are elevated, that diagnosis is NSTEMI. If the ST segments are not elevated and cardiac biomarkers are not elevated as well, the diagnosis is UA. In caring for any patient with an ACS, time is muscle. So the region of the heart supplied by the blocked artery is called the area at risk. The longer the area at risk is deprived of oxygen and nutrients, the greater the likelihood of permanent damage. Therefore, if myocardium is to be saved, the blockage must be removed before irreversible tissue death will occur. So if blood flow is quickly restored, the area at risk can potentially be salvaged. Of those patients that experience ACSs, those who are experiencing an STEMI are most likely to benefit from reperfusion therapy. The benefits of reperfusion therapy are often going to be time dependent as well. What you see here in this picture are going to be zones of ischemia, injury, and infarction showing indicative electrocardiogram changes as well as reciprocal changes corresponding to each zone. The area supplied by a blocked coronary artery goes through a sequence of events that have been identified as zones of ischemia, injury, or infarction. So each zone is going to be associated with certain characteristical ECG changes that are going to affect the shape of the QRS complex, our ST segment, and the T wave as well. So just to cover contiguous leads just a little bit more. So indicative changes are going to be significant when they are seen in at least two contiguous leads. So once again, at least two contiguous leads. And how we define two leads that are contiguous is if they look at the same, or if they look at adjacent areas of the heart, or if they are numerically consecutive chest leads. That is what we would consider two leads to be contiguous. So the areas of the heart as seen by the chest leads is going to be what we're looking at in this figure right here. Leads 1, 2, and 3 are contiguous. Leads 3, 4, and 5 are contiguous, as well as V4, 5, and V6. What I do want you to note is that neither the right ventricle wall, which is where you see the X in sort of like the center of this figure, nor the inferobasal, or what we call the posterior surface of the left ventricle, which is where the Y is, once again sort of in the middle of the figure just across from X, is going to be well visualized by any of those of the usual 6 chest leads. In the standard 12-lead ECG, leads 2, 3, and AVF view the inferior wall of the left ventricle, which is supplied by the right coronary artery, or what we'll call the RCA, in most people. So if an ECG shows STE in these leads, it is reasonable to suppose that these ECG changes are caused by partial or even complete blockage of the RCA. When indicative changes appear in the leads viewing the septal, anterior, and or the lateral walls of the left ventricle, for example, V1 to V6, lead 1 and AVL, it is reasonable to suspect that the left coronary artery is partially or completely blocked. So to evaluate the relative extent or size of an infarction, what we need to do is determine how many leads show indicative changes. So an ECG showing changes on only a few leads suggests a smaller infarction than one that produces changes in many leads. In general, the more proximal the blockage in the vessel, the larger the infarction and the greater the number of leads showing indicative changes. It is also important to emphasize that the approach discussed here with regard to localization of an infarction, so for example, determining which and how many coronary arteries are affected, works reasonably well for the STEMI. However, when we get into ST segment depression as well as T wave changes that suggest the presence of an MI or myocardial ischemia, as in non-ST elevation acute coronary syndromes, they are going to be less reliable in localizing the culprit vessel, mainly because the ECG changes reflect subendocardial rather than transmural ischemia. So what you're looking at here is another figure, and what we're going to be looking at is which of these leads show ST segment elevation, and are they anatomically contiguous leads. So what I want you to do is look at this ECG. You can pause this video for a second to study it, look at it in detail, and see if you can answer these questions. And on the next slide, we're going to go over the answers. So this ECG does in fact show ST segment elevation of more than 1 milliliter in leads 2, 3, and AVF. So an inferior wall infarction is suspected to be the cause of the ST segment elevation. We are also seeing that they are anatomically contiguous leads. So now we're going to get into specific types of infarctions. The first one we're going to talk about is left coronary arteries. So the left main coronary artery is going to supply the left anterior descending artery and the circumflex artery. Anterior infarction is what we're going to be talking about here, and as we look at these figures and pictures as well on the slide. So occlusion of the mid portion of the left anterior descending artery, also known as the LAD, is going to result in an anterior infarction. So proximal occlusion of the LAD may become an anteroseptal infarction if the septal branch is involved, or an anterolateral infarction if the marginal branch is involved. So if the occlusion occurs proximal to both the septal and diagonal branches, an extensive anterior infarction will result. Now we're going to be talking about a septal infarction. So the septum, which is going to contain the bundle of His and bundle branches, is normally going to be supplied by the LAD artery, which remember stands for left anterior descending. Because leads V1 and V2 face the septum, ECG changes of infarction are seen in these leads if the site of the infarction is limited to the septum. So a blockage in this area may result in the right and left bundle branch blocks, second degree atrioventricular or AV block type 2, and third degree AV block as well. Now to get into an anterior septal infarction, what I want you to note here is the ST segment elevation that you see in leads V1 through V4. So you can see on these, just sort of as a reminder, that they're labeled. If you can see V1's in the top sort of middle, then V2 below it, V3 to the right of V1. So the top furthest right is V4, below that V5, below that V6. So leads V3 and V4 face the anterior wall of the left ventricle. ECG changes of infarction will be visible in V1, V2, V3, and V4 if the entire anterior wall is involved. So once again, V1, V2, V3, and V4 if the entire anterior wall is involved. Increased sympathetic nervous system activity is common with anterior MIs, with resulting sinus tachycardia, hypertension, or even both. An anterior wall MI may cause dysrhythmias, including things like PVCs, atrial flutter, AFib, things of that nature. Now, although some portions of the bundle branches are supplied by the RCA, The left coronary artery supplies most of the bundle branch tissue. So, thus, those bundle branch blocks may occur if the left coronary artery is blocked. So, ventricular activation and R wave progression is what we're looking in this picture is going to be viewed from the chest lead specifically. In normal R wave progression, the QRS complex is negative in V1, positive in V6, and switches from negative to positive in the V3 to V4 transition zone. The wave of ventricular depolarization in the major portions of the ventricles is normally from right to left and in an anterior to posterior direction. So, when viewing the chest leads in a normal heart, the R wave becomes taller, meaning it increases in amplitude, and the S wave becomes smaller as the electrode is moved from right to left. So, this pattern is what we call the R wave progression. In V1 and V2, the QRS deflection is going to be predominantly negative, which means it's going to be moving away from the positive chest electrode. And this is going to reflect depolarization of the septum and right ventricle. So small R wave, and the left ventricle, which is going to be a large S wave. As the chest electrode is placed farther left, the wave of depolarization is moving toward that positive electrode. Our transition zone is going to be the area at which the amplitude of the R wave begins to exceed the amplitude of the S wave. This is usually going to occur in the area of leads V3 and V4. And the phrase early transition is going to be used when the transition is seen in V2. Late transition is going to describe a delay in transition until leads V4 and V5. Electrode placement in the correct intercostal space is going to be absolutely critical in evaluating our R wave progression. So what we're seeing here is going to be poor R wave progression in V1 through V4. We're also seeing a QRS that is greater than 0.12 second, as well as a left bundle branch block. So poor R wave progression is a phrase used to describe R waves that decrease in size from V1 to V4. So if you look at this little ECG strip that we have here, you can see that the R waves are decreasing in size from V1 as we go through V4. Now, this may be a non-specific indicator of an anterior wall infarction, but it may also be a normal variant in young people, particularly in young women. Other causes of poor R wave progression are going to include left triple B, right or left ventricular hypertrophy, and severe chronic obstructive pulmonary disease, particularly when we're talking about emphysema. Now, when we get into a lateral wall infarction, so the coronary artery anatomy shows blockage of the circumflex CX artery, which is going to be A on here, blockage of the proximal left anterior descending artery, B on this figure, and blockage of the diagonal artery, which is what you'll see as C on this picture here, LAD, which is the left anterior descending, as well as RCA, which is the right coronary artery. So when you're looking at the heart picture, that is how they're all going to be labeled and what those stand for. So leads 1, AVL, V5, as well as V6 are going to view the lateral wall of the left ventricle. Because the lateral wall of the left ventricle may be supplied by, excuse me, the circumflex artery, the LAD artery, or even a branch of the RCA, a lateral infarction may be associated with an anterior, inferior, or even a posterior infarction. An isolated lateral infarction is most commonly going to be associated with a circumflex artery occlusion. Now, just to continue on with the lateral infarctions, when we look at this here, what we're seeing is lead 1 shows a small Q wave with ST segment elevation, so STE. A larger Q wave with STE can be seen in lead AVL as well. So this patient had an anterior non-ST segment elevation infarction 4 days earlier with STE and T wave inversion in leads V2 through V6. A coronary arteriogram at the time also showed a blocked left anterior descending artery distal to its first large septal perforator. So the STE evolved and the T waves in all of the chest leads had become upright the day before this tracing was recorded. The patient then had another episode of chest pain associated with the appearance of signs of acute lateral infarction, as shown in this tracing that appears on this slide. So what happened then was a repeat coronary arteriogram showed new blockage of the obtuse marginal branch of the circumflex artery. So coronary anatomy is going to show a dominant right coronary artery. So the RCA was what you can see in this picture here. A blockage at point A, so find A, point A, results in an inferior infarction and right ventricle infarction. A blockage at point B, so once again, find B on the heart here, almost in the center left, involves only the inferior wall, sparing the right ventricle there. Now, leads 2, 3, and AVF view the inferior surface of the left ventricle. In most individuals, that inferior wall of the left ventricle is supplied by the posterior descending branch of the RCA. Now, increased parasympathetic nervous system activity is common with inferior MIs, which ends up resulting in bradydysrhythmias. Conduction delays, for example, first degree AV block, second degree AV block type 1, are also going to be common and are usually transient. So with an inferior wall infarction, with the coronary anatomy here, so the picture of the heart, is going to show a dominant circumflex artery, which you'll see noted as CX. And we're also going to see a blockage at point A that is going to result in an inferior infarction. There's also a blockage at point B, which may result in a lateral and inferobasal infarction. You'll also notice in this picture the left anterior descending labeled as LAD artery. So when looking at this ECG strip here, what I want you to know is that the ST segment elevation in leads 2, 3, and AVF, as well as the reciprocal ST segment depression in leads 1 and AVL. So inferobasal infarction, which is what we're looking sort of at here, is a coronary anatomy is going to show us a dominant right coronary artery or the RCA, and occlusion of the RCA will commonly result in an inferior and inferobasal infarction. So the inferobasal, or what is also known as the posterior infarctions, usually occur in conjunction with an inferior or lateral infarction. So the inferobasal wall of the left ventricle is supplied by that circumflux artery in most patients. However, in some patients, it is supplied by the RCA. And because no leads on a standard 12 lead ECG are going to directly view the posterior wall of the left ventricle, we're going to need basically additional chest leads, the V7 to V9, may be used to view the heart's posterior surface. Indicative changes of a posterior wall infarction are going to include things like ST segment elevation in these leads. So with the inferobasal infarction, the coronary anatomy here is going to show us a dominant circumflex artery, and it's going to also show occlusion of a marginal branch, which is the cause of most isolated inferobasal infarctions. So application of the mirror test is what we're sort of looking at here in this picture. And what this test is it's the most helpful test in assessing a patient with an acute inferior infarction. So it's also going to be in somebody that we suspect an acute inferobasal infarction as well. So in figure A, which is going to be the top picture here, what we're looking at is a schematic 12-lead ECG with indicative changes of inferior infarction in lead 3. And what I really want you to note here is the tall R wave in lead V1 and the ST segment depression in leads V1, V2, and V3. As you move on to picture B here on the bottom, what we're looking at is the tracing in the tracing in figure A is now flipped over. So we're looking at it upside down. And looking through the paper, so sort of as it's held up to the light, you can now see Q waves as well as ST segment elevation in leads V1, V2, and V3. So this is a positive mirror test. And what a positive mirror test suggests is that the lead changes observed in A may reflect in figure A, just to make sure, may actually reflect associated acute inferobasal infarction. So in this picture here, what we're looking at are evolutionary changes in a posterior inferior myocardial infarction. So control tracing is going to be normal here. On the tracing recorded 2 hours after onset of chest pain, demonstrated development of early Q waves, marked ST segment elevation, and hyperacute T waves in leads 2, 3, and AVF. In addition, a larger R wave, ST segment depression, and negative T waves have developed in leads V1 and V2. These are early changes that are indicating acute posterior inferior myocardial infarction. So the 24-hour tracing, is going to demonstrate these evolutionary changes. In leads 2, 3, and AVF, the Q wave is larger. The ST segments have almost returned to baseline, and the T wave has begun to invert. In leads V1 to V2, the duration of the R wave now exceeds 0.04 seconds. The ST segment is depressed, and the T wave is upright. So when you're looking at this example, the ECG, the changes of true posterior involvement are going to extend past lead V2. And ordinarily, only leads V1 and V2 may be involved. Only minor further changes occur through the 8-day tracing. And finally, 6 months later, the ECG illustrates large Q waves, isoelectric ST segments, and inverted T waves in leads 2, 3, and AVF, and large R waves, isoelectric ST segment, and upright T wave in leads V1 and V2, which is all indicative of an old posterior inferior myocardial infarction. So once again, just as you're looking at this, you'll see the top one is our control. You'll see the word control just below it. Then you see 2 hours later, 24 hours later, 48 hours later, 8 days later, and then 6 months later, just so you're getting a better understanding of how he's explaining those and what you're looking at throughout it. So what we're looking at here is we're going to start by looking at the heart real quick. So what we're really looking at here is a right ventricular infarction, is what we call RVIs. So the first thing I want you to look at is the letter A at the heart with the arrow pointing to it, and then we're also going to be talking about the letter B and pointing to that. All right. So we're going to start with the letter A, and what that is showing is a blockage of the right coronary artery proximal to the ventricular marginal branch. And what this will result in is an inferior infarction and RVI. When you look at B, what we're looking at is blockage of the right ventricular marginal branch, which results in an isolated RVI. Just as a reminder, that LAD artery that you see on here as well, that's the left anterior descending. And then when you see that RCA, it stands for right coronary artery, just as a reminder. So a right ventricular infarction, or that RVI, is usually a consequence of RCA, or right coronary artery occlusion. However, that CX, or circumflux artery, supplies a significant proportion of the right ventricle in about 10% of patients. So although the RVI may occur by itself, it has been estimated that about 1/3 of patients with inferior MI experience an RVI. Right-sided chest leads should be used to help evaluate for evidence of an RVI in all patients with inferior STEMI, or STEMI. And what should be used is the V4R, having the highest sensitivity to it. So what you're looking at here in your leads is an inferior infarction and a right ventricular infarction, okay? So an RVI is in here as well. So this is just giving you an overall picture of what that looks like in regards to what we just covered on the last slide. Now we're going to move into intraventricular. So what you're looking over here in this picture is the cardiac conduction system. So you're looking at the AV, AV, which is also going to stand for atrioventricular, the LBB, which is our left bundle branch, and the RBB, which stands for the right bundle branch as well. You'll see the sinus node in here, also known. You'll see the bundle of His as well. So this is just giving you an overall picture of that conduction system. So after passing through the AV node, that electrical impulse is going to enter the bundle of His, which is normally the only electrical connection between the atria and the ventricles. The bundle of His conducts the electrical impulse to the right and left bundle branches. A bundle branch block, a triple B or BBB, is a disruption in impulse conduction from the bundle of His all the way through either the right or the left bundle branch to the Purkinje fibers. A triple B or BBB may be intermittent or permanent, complete or incomplete. The right bundle branch is going to travel down the right side of the interventricular septum to conduct the electrical impulse to that right ventricle. Structurally, the right bundle branch is long it's going to be thin, and more fragile than the left. And because of its structure, a relatively small lesion in the right bundle branch can result in delays or interruptions in electrical impulse transmission. The left bundle branch is going to begin as a single structure that is short and thick and then divides into two subdivisions that are called the anterior fascicle and the posterior fascicle. The anterior fascicle spreads the electrical impulse to the anterior portions of the left ventricle. Now, this fascicle is thin and vulnerable to disruptions in electrical impulse transmission. The posterior fascicle is going to the posterior fascicle relays the impulse to the posterior portions of the left ventricle. It is short, thick, and rarely disrupted because of its structure and dual blood supply from both the artery and the RCA. In some people, a third fascicle, which is called the medial fascicle or septal fascicle, emerges from the left bundle itself or its posterior inferior division. So what you're looking at here in this picture is the sequence of normal ventricular depolarization and resulting QRS complex as it's seen in leads V1 and V6. So you'll see on the bottom left V1, the right here V6. So the wave of normal ventricular depolarization moves from the endocardium to the epicardium. And the left side of the interventricular septum, which is stimulated by the left posterior fascicle, is going to be stimulated first. The electrical impulse, or the wave of depolarization, then traverses the septum to stimulate that right side. So both the left and right ventricles are then going to be depolarized at the same exact time. A delay or block is going to occur in any part of the intraventricular conduction system. So if a delay or block occurs in one of the bundle branches, the ventricles will not be depolarized at the same time. The electrical impulse travels first down the unblocked branch and stimulates that ventricle. And because of the block, the impulse must then travel from cell to cell through the myocardium rather than through the normal conduction pathway to stimulate that other ventricle. The ventricle with the blocked bundle branch is going to be the last to be depolarized. When one of the bundles becomes blocked, the impulse that is normally conducted by the bundle branch is going to be interrupted, and it does not depolarize the intended ventricle. Meanwhile, the other bundle branch is conducting its impulse and depolarizing its respective ventricle. So, for the second ventricle to depolarize, the electrical impulses must trudge through myocardial cells, which are not specialized for electrical conduction. So, thus, the impulses from one ventricle must be transmitted cell by cell to the other ventricle. Because the impulses are not traveling down that normal conduction pathway, ventricular depolarization takes longer to occur. And this delay is going to be evident in the form of a wide QRS complex. Variation in QRS duration from lead to lead is often going to be seen and may even produce some confusion about whether the complex is wide or not. As a rule, we're going to use the widest QRS complex to determine the width. So what you want to try to do is pinpoint the exact beginning and end of that QRS complex. This can be a little bit difficult to do and is sometimes even impossible. So therefore, when you're measuring for that triple B, We want to select that widest QRS complex with a discernible beginning and end. So the criteria for that BBB or triple B recognition may be identified at any lead on that ECG. However, in differentiating the right bundle branch block from the left bundle branch block, you want to pay particular attention to the QRS morphology or shape in specific leads. Lead V1 is probably the single best lead to use in differentiating between forms of bundle branch blocks. So to be considered a bundle branch block or triple B, the following ECG criteria need to be met. So 1, the QRS duration of 0.12 second or more in adults. If it's a complete right bundle branch block or a left bundle branch block, I can't say that 3 times fast. So if a triple B pattern is discernible and the QRS duration is between 0.11 and 0.119 second in adults, it's called an incomplete right or left bundle branch block. If the QRS is wide, but there is no triple B pattern, the term wide QRS or even intraventricular conduction delay is used to describe the QRS, just so you guys understand that. So visible QRS complexes are going to be produced by supraventricular activity. So for example, the QRS complex is not a pace beat and it does not originate in the ventricles. Sort of just another slide talking about what I just went over. Just sort of repeat real quick. If that triple B pattern is discernible and that QRS duration is between 0.11 and 0.119 second in adults, it is going to be called an incomplete right or an incomplete left bundle branch block. Same thing here, talking about that intraventricular conduction delay is going to be used to describe the QRS. If the QRS is wide but there is no bundle branch block pattern. So what you're seeing here is a sequence of ventricular depolarization for a right bundle branch block and resulting QRS complex as seen in leads V1 and V6. So as you can see, bottom left V1, a little bit to the right there is V6. So with a right bundle branch block, the electrical impulse is going to travel through the AV node and down the left bundle branch into that intraventricular septum. So the septum is going to be activated by the left posterior fascicle and is depolarized in a left to right direction. So thus the septal depolarization moves in a left to right direction, which is toward V1 and produces an initial small R wave. So as the left bundle continues to conduct impulses, the entire left ventricle is depolarized from right to left. So what this does is it produces movement away from V1 and results in a negative deflection. So an example would be an S wave. So now that the impulses that depolarize the left ventricle conduct through the myocardial cells and depolarize that right ventricle. So what this depolarization does is it creates a movement of electrical activity in the direction of V1. And so what we'll see is a second positive deflection is going to be recorded, which is R. So the RSR pattern is characteristic of a right bundle branch block. And the RSR pattern is sometimes going to be referred to as an M or rabbit ear pattern. So here you're looking at the sequence of ventricular depolarization for a left bundle branch block and resulting QRS complex here as what we see in leads V1 as well as V6. So once again, bottom left here is V1, to the right is V6. So with the left bundle branch block, the septum is going to be depolarized by the right bundle branch, as is the right ventricle. So the septum is part of the left ventricle and is normally depolarized by the left bundle branch. Because that left bundle branch is blocked, depolarization of the septum by the right bundle branch occurs in an abnormal direction. So, for example, from right to left. Now, thus, the wave of myocardial depolarization begins with the net movement of current going away from V1 and is recorded as an initial negative deflection. So the right ventricle is depolarized next. Because the wave of depolarization moves briefly toward the positive electrode in lead V1, a small upright notch in that QRS complex is going to be seen on the ECG. As the remainder of that left ventricle is depolarized, the QRS complex is inscribed in lead V1 as a deep negative deflection, so an S wave, for example, which is a reflection of that left ventricle's large muscle mass. So sometimes depolarization of the left ventricle will overshadow that of the right ventricle on the ECG. And when this occurs, a QS deflection is going to be inscribed in lead V1. And the small upright notch that is usually seen with right ventricular depolarization is going to be absent. So what you're looking at here are just different variant patterns of bundle branch blocks as we would see them in lead V1. And much like this says, unfortunately, everything that I just described in the previous slides about bundle branch blocks, not every triple B is going to present with that same clear pattern, that I just described, which makes the different the ability to differentiate between that right and left bundle branch block a lot less clear and can make it a little bit difficult in regards to this. So you'll see the top one here, the normal right bundle branch block, and then a variant of it, and then on the bottom here we have that left bundle branch block, okay, and then a variant to the right of that as well. So when we're determining the direction here of the terminal force, in lead V1, we're going to move from the J point into the QRS complex and determine whether the terminal portion, so basically the last 0.04 second of the QRS complex, is a positive, meaning upright, or a negative, meaning downward deflection. So what I want you to remember is that in the setting of a bundle branch block, the ventricles are not depolarized in their normal simultaneous manner. So instead, they are depolarized sequentially. So the last ventricle to be depolarized is of course the ventricle with the blocked bundle branch. So therefore, if it is possible to determine which ventricle was depolarized last, it becomes possible to determine which bundle branch was blocked. So that's sort of an easier way to look at this. So for example, if the right ventricle was depolarized last, it is because the impulse traveled down the left bundle branch, depolarized the left ventricle first, and then marched through and depolarized that right ventricle. So it stands to reason that if one ventricle is depolarized late, its depolarization makes up the latter portion of the QRS complex. So what you'll see is if we have a positive, it's going to be a right bundle branch block, and if we have a negative, it's going to be a left bundle branch block. We also have what we call the turn signal theory, and when we're determining the direction of the terminal force, In lead V1, we're going to move from the J point into the QRS complex, and we're going to determine whether that terminal point, so that last 0.04 seconds of the QRS complex, is positive or negative, just like I mentioned before. And what we're differentiating here between is the right and left bundle branch blocks. The turn signal here, that the turn signal theory, is that right is up and left is down. So a simple way to remember this rule has been suggested by both Mike Tegman and Sid Kanan, I believe is how you say their last name. And what they recognize is the similarity between this rule and the turn indicator on a car. So to indicate a right turn, you lift up the arm of the turn signal. And likewise, when we have a right bundle branch block and it's present, the terminal force of the QRS complex points up. And conversely, left turns and left bundle branch blocks move downward. So you'll see the first picture where you're seeing the J point is going to be up, meaning that it's a right bundle branch block. And the second J point, is going to be down, so that is going to be a left bundle branch block. So this is the turn signal theory. Just different ways for you guys to think about it. Everybody learns and remember things differently. So these are just some different tips and ways to sort of reframe how we can try to determine the difference between the left and right. So the criteria used to recognize a bundle branch block are valid, but they do lack some sensitivity and specificity. So the sensitivity can be limited by junctional rhythms because there may be no discernible P waves when the AV junction is the pacemaker site. The AV junction is a supraventricular pacemaker, but this presents as an exception to the two-part rule of the bundle branch block recognition. Specificity is going to be limited by the WPW or Wolff-Parkinson-White syndrome and other conditions that produce wide QRS complexes that resulting from that atrial activity. So if the characteristic delta wave and shortened PR interval are recognized, the Wolff-Parkinson-White or WPW syndrome should be suspected. So when it comes to differentiating between the left bundle branch block and the right bundle branch block, a third category sort of does exist. And that's non-specific intraventricular conduction delay, or what we call NSIVCD. So once again, non-specific intraventricular conduction delay, NSIVCD. And these blocks do not display the typical V1 morphologies generally produced by our bundle branch blocks. So their origin may not be the result of a complete bundle branch block, but they often are the result of several factors, of which incomplete bundle branch blocks may be one of them. So atypical patterns of bundle branch blocks can be attributed to the NSIVCD here. So when it comes to bundle branch blocks and what causes it, first I want to talk about the right bundle branch block. So this can occur in individuals with no underlying heart disease, but it typically occurs more commonly in the presence of organic heart disease, with coronary artery disease being probably the most common cause. And acute right bundle branch blocks may occur secondary to a right ventricular infarction. When it comes to the left bundle branch block, this may be acute and it may also be chronic as well. The acute left bundle branch block may occur secondary to an anterior-septal, which is going to be more common, or inferior MI. Acute heart failure may be another, and even acute pericarditis or myocarditis, among many other causes as well. So this is sort of talking about the causes of that left bundle branch block, whether it may be acute or chronic. So, other causes of the bundle branch blocks are going to include things like aortic valve disease, congenital hypertensive, um, rheumatic heart disease as well. Trauma, cardiac surgery, for example, would be an example of trauma. And even sometimes the ECG will show occasional QRS complexes that have a right bundle branch block or a left bundle branch block morphology interspersed with normal QRS complexes. So when the intermittent triple B or BBB is related to the patient's heart rate, it is referred to as a rate related bundle branch block. So, for example, the RR intervals of the QRS complexes that show bundle branch blocks, are shorter when compared with the RR intervals of the normal QRS complexes. Non-ischemic diseases are also capable of producing a bundle branch block as well. All right, now we're going to go ahead and get into chamber enlargement. All right, first I just want to talk about what cardiomyopathy is. And what this is a general term that is used to describe different types of heart diseases that involve the heart muscle and result in abnormal enlargement. You're going to also hear the term cardiac enlargement. And what this is going to refer to is either a dilation of a heart chamber or hypertrophy of the heart muscle itself. Now, with dilation, stretching of a chamber of the heart muscle occurs, resulting in enlargement of that chamber. Now, the dilation may be either acute or it could be chronic as well. Another term you're going to hear is cardiac hypertrophy. And what this refers to is the thickening of the heart muscle with resultant enlargement of the heart chamber. So the hypertrophy is going to be commonly accompanied by dilation. So when we're evaluating the ECG for different indications of chamber enlargement, what's going to be important to check is the calibration marker to ensure that it's 10 millimeters or 1 MV tall. So the three types of cardiomyopathy are going to be listed here. We have dilated, hypertrophic, and restrictive. So when you look at these pictures here, A is going to be a normal heart, B is going to be dilated cardiomyopathy, C is going to be hypertrophic cardiomyopathy, and D is going to be restrictive cardiomyopathy. So what you're going to see here is in B, the dilated cardiomyopathy, what we're seeing is an enlargement of all four chambers. Whereas when we move to the hypertrophic cardiomyopathy, we're showing a thickened left ventricle specifically. So you can see in the letter C figure here that the left ventricle is thickened. As we move to D in the restrictive cardiomyopathy, what we're seeing is a small left ventricular volume. So what you're looking at here are going to be criteria for atrial abnormalities. So right atrial abnormality, or RAA, produces changes in the initial part of the P wave. So if you look at that P wave, it is more than 2.5 millimeters tall. The P wave is going to be tall, like I just said, 2.5 millimeters in height. It's peaked and usually of normal duration. When we move into left atrial abnormality, or LAA, the middle and end of the P wave is prolonged because that depolarization of the left atrium begins and ends later than the right atrial depolarization. Notched P waves are usually going to be visible, and they're generally most easily going to be seen in the limb leads as well. Now, when the ECG reflects features of both right atrial and left atrial abnormality, the term combined atrial abnormality is used. So what we're looking at here is ventricular hypertrophy. So with left ventricular hypertrophy, or LVH, what it does is it increases the amplitude of electrical forces directed to the left and posteriorly. In addition to that, repolarization abnormalities can cause ST segment depression and T wave inversion in leads with a prominent R wave. Now, with right ventricular hypertrophy, or RVH, it can shift the QRS vector to the right, usually with an RS or QR complex in lead V1, especially when caused by severe pressure overload. T wave inversion may also be present in the right chest leads. So what we're looking at here is an ECG strip that is showing RVH, or right ventricular hypertrophy. And what we're seeing with this is we're seeing tall R wave in the right precordial leads. We're also seeing downsloping of the ST depression in the chest leads. We are seeing right axis deviation, as well as evidence of right atrial enlargement. I'll leave this up just for a second so you can go through this ECG strip and do a little bit of looking at each of these, looking at the ST depression, that R wave, the right axis deviation in this strip here. All right, now what we're doing is we're looking at a ECG strip of LVH, left ventricular hypertrophy. So what I want you to note in this is that the ST segment is going to be elevated in leads V1, V2, and V3. So although there's several formulas exist to assist in recognizing the LVH, the Cornell voltage criterion is often going to be used to check for the presence of LVH. So to use this formula, what we're going to do is we're going to add the S wave amplitude in lead V3 and the R wave amplitude in lead AVL, and a total greater than 20 millimeters or 2 MV in women and 28 millimeters or more or 2.8 MV in men is going to suggest that LVH is present. So that's the main formula that we use in determining LVH. Now we're going to go ahead and head into electrolyte disturbances. So the first thing, so the first thing we're going to talk about here is sodium. And sodium is going to be the most abundant electrolyte in our body. And it makes up about 90% of the positively charged ions or cations in the extracellular fluid. It is important in maintaining water balance. It is necessary for the normal conduction of impulses in nerve and in muscle fibers, in conjunction with potassium and calcium also. But it plays an important role in the voltage of action potentials. Our diet is going to be the primary source of our sodium. And in healthy individuals, excess sodium is excreted in the urine. So we're talking about hypernatremia now, which is what we call sodium excess. And what this may actually result in is from basically the retention of relatively more sodium than water, or it may even be caused by a loss of relatively more water than sodium. So, some possible causes of hypernatremia because of the retention of relatively more sodium than water are going to include things like excess aldosterone secretion, excess secretion of adrenocorticotropic hormone, also known as ACTH. That's a hard one. Hypertonic parenteral fluid administration. It could also be from things like inadequate fluid intake or even ingestion of abnormal amounts of sodium. Some possible causes of hypernatremia because of a loss of relatively more water than sodium are going to be including things like diabetes insipidus, severe watery diarrhea could be another one, and even severe insensible water losses. So things like heat stroke or even a prolonged high fever would qualify as that. So, with hypernatremia, some possible signs and symptoms that the patient may present with are going to be things like restlessness, irritability, thirst, flushed skin, dry mucous membrane, so things like the nose, the mouth, decreased urine output, seizures, and even coma. Hypernatremia does not cause any significant changes in the ECG, though. So when you're looking at a strip, you shouldn't see any significant changes caused by hypernatremia specifically. Now, hyponatremia is going to be a sodium deficit. And what this may result in is from an inadequate intake of sodium, could be from a dilution of sodium by water excess, or where there's a loss of sodium. So hyponatremia, so hyper always means high, hypo always means low, alters the action potential in neurons and muscle because of changes in the cell's ability to depolarize and repolarize. So there are a few possible causes of hyponatremia, and these are going to be things that include inadequate sodium intake, so not getting enough sodium, prolonged diuretic therapy, um, excessive diaphoresis, um, Excessive loss of sodium from trauma. So, an example of that would be like a burn. Adrenal insufficiency, renal disease, any severe gastrointestinal or GI fluid losses from either gastric suctioning or lavage. Any prolonged vomiting or diarrhea would be a part of that as well, of causes that would lead to hyponatremia. Some medications like morphine and barbiturates may also impair water excretion and could contribute as well to hyponatremia. So, what we may see as far as signs and symptoms with the patient are going to be things like irritability, fatigue, headache, nausea, vomiting, abdominal cramps, muscle weakness as well. Hyponatremia is just like hypernatremia, is not going to cause any significant changes in that ECG strip either. So potassium is going to be the primary intra cellular fluid cation, and it is important for many different types of cell functions. Things like our cardiac, our neuromuscular activity, our resting membrane potential, growth, and even regulation of the fluid volume and pH in the cell. So potassium is going to be extremely important. Now, hyperkalemia, which was going to be excess potassium, may occur because of acute or chronic renal failure. It might be due to excessive administration of intravenous potassium, metabolic acidosis. It could even be from ingestion of excessive amounts of salt substitutes, medications, um, widespread cell damage like crushing injuries or burns. Um, and with this, the patient may even present with anxiety, restlessness, cardiac dysrhythmias, skeletal muscle weakness would be one potentially, and abdominal muscle cramping and even diarrhea. So when it comes to the effects of hyperkalemia, it's really going to depend on the tissue that's involved. With the atrial myocardium being the most sensitive to hyperkalemia, the ventricular myocardium is going to be less sensitive, and the SA node and the bundle of His the least sensitive of them all. Now, when the potassium level exceeds 5.5 MEQ per liter, what we're going to see is tall peak T waves may be seen on the ECG. However, though, about 50% of patients with the potassium levels higher than 6.5 MEQ per liter will manifest, will not manifest, let me make sure I'm saying this correctly, will not manifest any ECG changes. So about 50% of patients with potassium levels higher than 6.5 will not manifest any ECG changes. And as the potassium levels rises, what we're going to see are PR intervals are lengthened and the QRS duration increases, which is going to sort of reflect slowed conduction. So when the potassium level nears 10, what we're going to see is intraventricular conduction delays and dysrhythmia, such as ventricular tachycardia, ventricular fibrillation, and asystole may even develop. And as the potassium level rises, PR intervals lengthen and the QRS duration increases, reflecting that slowed conduction. So when the potassium level nears 10, the intraventricular conduction delays and dysrhythmia, such as that ventricular tachycardia, VFib, and asystole may develop. So what we're looking at here are going to be the effects of progressive hyperkalemia on the ECG. So all of the illustrations are from leads V3 that you're seeing here on the left side of your screen. What you're looking in A, which is going to be the top one, the serum potassium concentration, potassium is also known as K plus, was 6.8. And what you should really be looking at is the peaked T waves together with sinus rhythm. As we move into figure B, which is the middle one here, what we're noticing is serum potassium was 8.9. And another thing you should note with B is the peak T waves, and then there's an absence of P waves. So we're not seeing any P waves, but those T waves are still peaking. As we move into C, what we're seeing is the serum potassium was greater than 8.9. And what I want you to know about this one is the classic sine wave with absent P waves. And what we're seeing is marked prolongation of that QRS complex, and then we're still seeing those peaked T waves. Now, as we move into hypokalemia, remember that's going to mean potassium deficit, or low potassium. And this is one of the most common electrolyte disorders. It may occur because of prolonged diuretic therapy with thiazide diuretics or furosemide. An inadequate dietary intake of potassium could be another reason. We could see things like administration of potassium deficient parenteral fluids. We might see starvation as one, severe gastrointestinal fluid losses from gastric suctioning or lavage, things like prolonged vomiting or diarrhea, or even laxative use without replacement of potassium could potentially be another one as well. And it's been estimated that as many as 10% to 40% of patients taking thiazide diuretics and almost 50% of patients resuscitated from out of hospital VFib have low potassium levels. So once again, this is going to be a very common electrolyte disorder. So what you'll see here when it comes to ECG signs, what we're going to be looking at and seeing when we have a patient that has hypokalemia, they have that potassium deficit, we're going to see the ST segment depression. We're going to see a decrease in T wave amplitude. We're going to see prominent U waves. P wave amplitude and duration are going to be usually going to be increased. We're going to have a slight prolongation of the PR interval. And lastly, we're going to see an increased QRS duration when it comes to severe hypokalemia. So what you're seeing here is the ECG manifestations of hypokalemia. So the serum potassium concentration was 2.2. The ST segment is prolonged, and primarily because of a U wave following the T wave, and the T wave is flattened. Now, the patient may present with skeletal muscle weakness, fatigue, paresthesia, and as well, we'll see cardiac dysrhythmias, things like sinus bradycardia, atrioventricular blocks may be another one as well. Now, electrophysiological effects of hypokalemia are going to include things like increased automaticity. We're going to see decreased conduction velocity, shortening of the effective refractory period, and even prolongation of the relative refractory period as well. Now, when we talk about calcium, calcium is going to be extremely important in our bone formation, in our nerve and muscle function, as well as in blood clotting. So in hypercalcemia or calcium excess, this is going to include things like chronic and acute renal failure. It's going to include causes such as excessive vitamin D or vitamin A intake, hyperthyroidism, um, hyperparathyroidism, adrenal insufficiency, cancer, things like breast, ovarian, multiple myeloma, excessive use of calcium containing antacids, and even an excessive intake of calcium supplements. So the patient may present with things like nausea, vomiting, acute mental status changes ranging from mild confusion all the way to a coma. They may have skeletal muscle weakness, constipation, and even cardiac dysrhythmias. When it comes to ECG signs of hypercalcemia, what we're going to see is shortening of the ST segment as well as decreased QT interval duration. Now, when it comes to hypocalcemia, which is a calcium deficit, this may result from an inadequate intake of calcium or from increased excretion of calcium from the body. So that's possible results. And some other causes may be things that include acute or chronic renal failure, dietary deficiency of calcium and vitamin D, pancreatic disease, malabsorption because of small bowel disease, and hypoparathyroidism. When it comes to hypocalcemia, what we may see is the patient present with things like irritability and confusion, tingling of the nose, mouth, ears, fingers, or toes, nausea, vomiting, and diarrhea. Cardiac dysrhythmias may be another one. Hyperactive deep tendon reflexes, carpal spasms, and even facial muscle contraction and pathological fractures are possible as well. With hypocalcemia, what we're going to see on the ECG are lengthening of that ST segment and increased QT interval duration. So with hypocalcemia, once again, the ST segment is lengthened and the QT interval is prolonged. And with hypercalcemia, what you're going to see is the ST segment is shortened and the duration of the QT interval is decreased. So the opposite between hypocalcemia and hypercalcemia. What you'll see here, the middle is going to be a normal ECG strip. The left is the hypocalcemia, which you're going to once again see ST segments lengthen, the QT interval is prolonged. When you look at the hypercalcemia, we're seeing ST segment short and the QT interval is decreased. So magnesium is the next electrolyte we're going to be talking about here. And what we're going to be talking about is how magnesium is going to be important for many of our biological processes. So these are going to be things like enzyme reactions, neuromuscular function, including the cardiac muscle contractility as well, and the production and use of adenosine triphosphate. So with magnesium excess or hypermagnesemia, what we're going to see as far as causes are going to be things like renal failure, excessive use of parenteral magnesium, and excessive use of magnesium containing antacids or even laxatives as well. Now, what we may see is the patient may present with drowsiness, flushing, hypotension, decreased rate and depth of breathing, diminished deep tendon reflexes, and with hypermagnesemia, depresses the AV and intraventricular conduction. So with hypermagnesia, it does not produce significant ECG changes. So with hypomagnesemia or magnesium deficit, This may occur because of things like prolonged or excessive diuretic therapy, excessive calcium or vitamin D intake, administration of IV fluids or total parenteral nutrition without any type of magnesium replacement given. Hypercalcemia can cause hypomagnesemia. And then things like malabsorption, which can be associated with disease of the small intestine, malnutrition, and alcoholism as well. Now, as far as signs and symptoms, what we may see the patient present with are going to be things like acute mental status changes, tachycardia, cardiac dysrhythmias, muscle tremors, and muscle cramps, as well as hyperactive deep tendon reflexes. We're typically not going to see any significant ECG changes with our hypomagnesemia, but it has been implicated that it is a possible cause of torsatus de pointes. So that is something that, once again, it's implicated that this could be a cause of that. All right, so now what we're going to get into is the 5-step 12 lead analysis. So the first step that we're going to have here is we want to identify the rate and underlying rhythm. When we're looking at the ECG strip, we want to identify any premature beats and pauses if there are any present. So once again, we're identifying the rate and underlying rhythm. Then from there, we're going to move on to the identifying any premature beats and pauses if they're present. After we finish step 1, we're going to head into step 2. And step 2 is using lead 1 and AVF to determine the QRS axis. As we move into step 3, we want to identify and examine waveforms and measure intervals. Now, before examining waveforms, quickly look at the calibration marker and determine if it's standard, half standard, or twice the standard. Next, what you're going to want to do is examine each lead. What you want to do is select one good representative waveform or complex in each lead. And then you're going to inspect each waveform, noting any changes in orientation, shape, size, or duration. In step 4, we're going to examine for evidence of ischemia, injury, or infarction. I see all leads is a commonly used mnemonic to recall the lead groupings when we're localizing an infarction and when we're predicting which coronary artery is included. So how this works is the I in I see all leads refers to I means inferior, and that equals 2, 3, and AVF. S is septal, and that's going to be leads V1 and V2. A is anterior, which is going to be leads V3, V4. L is lateral, which is going to be leads 1, AVL, V5, and V6. And what you should do is look for the presence of ST segment displacement. For example, ST segment elevation or depression. Lastly, what you're going to do is look for evidence of chamber enlargement, look for any effects of any electrolyte imbalances, and ascertain if conditions that mimic MI are present. Things like LVH, left triple B, ventricular rhythm, or even ventricular paced rhythm. And that is your 5-step 12 lead analysis. That's going to sum up this last chapter. So once again, make sure you read to help sort of with some of this information. I know it's a lot. If you have any questions, need any further explanation, please make sure you send an email, k4@h2health.com, and we'll do our best to help you out. Thank you.